Today we are going to be talking about the Maitland versus Mulligan mobilization techniques. It's just a comparison of both techniques, and at the end it's a little bit of a literature review, and I will give my opinion on what technique I would use to treat shoulder impingement. So first off, I just wanted to start by saying a little what joint mobilizations are. Just these are just from a couple of articles I found. They're techniques used to increase soft tissue and capsular joint mobility or improvement in joint pain and mobility. So the main focus of joint mobilizations are really to see if your patient or athlete has some kind of limitation in range of motion or they're having pain with any movement, then joint mobilizations can be used to increase mobility. So there's two main techniques, Maitland mobilizations and then Mulligan mobilizations with movement. Here are a couple pictures I have found on the internet. Maitland mobilizations are very much with clinicians' hands, and there it's the subject is just laying there, and we're passively moving the joint. And then with Mulligan, the patient is usually either in a weight bearing or some kind of functional position going through movement, and they're the ones kind of controlling the end range of motion and how much they move. We're just applying the pressure. So here are some main things about Maitland mobilizations. So they're skilled, slow, passive movements, like I said earlier. The thing with Maitland mobilizations, well, actually just any mobilizations in general, you really need to know your anatomy and have a good grip on the movement and what areas of the bone articulate together and the shapes of the bone, movement of the muscles. The main thing with Maitland's, there's a convex concave rule. So you're looking at the surfaces and how they interact. Let's say that you have let's see here, the humerus head and the glenoid fossa. The humerus head would be the convex surface, and the glenoid fossa would be the concave. And then you look at, okay, so which one is going to be the stationary part, and which one is going to be the movable. So that situation, the humerus would be the ones that we can move because the scap and the glenoid are stationary. So then you would go to so concave would be the surface and stationary. So then we want to do the convex motion rule. And this is a lot, I know, that I'm saying, and I don't expect you guys to remember all of this, but I just want to kind of give you a brief overview of what these are. So the convex motion rule, that is when the osteo and arthritic motions are opposite. So then the motion is in the opposite direction of what you actually want to increase. So if I want to increase the anterior capsule, I will be going in the opposite direction. And then so if it was a concave motion rule, the convex is stationary, and the concave would be the one we're moving. This kind of works with the tibia, the femur, and you would be going actually in the same direction as that you want. So I know this is hard, especially when you're not looking at pictures or anything. So just, I guess, before you try to do Maitland's, you really need a good grasp on the body and the way it works. You also need to know the types of grades that there are for Maitland's mobilization. So there are 5 grades. Grades 1 and 2 are used to decrease pain mostly. Grades 3 and 4 are then used to increase range of motion, and then grade 5 is actually a manipulation. So I stick with grades 1 through 4, and there's charts and all that that show you exactly what to do for which grade, and if you want to do oscillations or if you want to do more of a um, holding pull for 10 seconds, then you can do that too. So Maitland's is, I guess what I want you guys to get away with this is that Maitland's is all the clinician's hands and their movement and their, I guess, it's their feel of what they think, how far they can push. And so that is what Maitland's is about. You can do slow, fast oscillations. It has it all set up and it is very procedural. They have definitely a set thing for each thing you want to do. So if you want to decrease range of motion, not decrease range of motion, but decrease pain, and your athlete is not to the point where you want to increase range of motion, then there's a set procedure for that. So that is the one thing about Maitland's that is pretty cool. Not the one thing, but the one thing that differs from Mulligan's. Mulligan's mobilizations with movements. These are sustained passive glides. So that is when as a clinician, you are holding the joint into a position, but the athlete is then, or a patient is going through range of motions. And so you're working together. If the athlete starts to feel discomfort, then you stop. You can work your way up to 10 reps, but if the athlete starts to feel discomfort on rep 6, then that's what you do for the day. So they can take it as far as they want. There's a thing called overpressure that you need to know. It's a point where you can, in the range of motion that is, you passive range of motion, and to get there, you as a clinician can add a little bit more pressure, but you can only do that for Mulligan's if it is pain-free, and then that is known as a very successful technique, is when you get into the end range of motion, there's not having any pain more, and then you just give a little bit more pressure to increase that range of motion, and that has been very successful in the past. With Mulligan's techniques, I like these because they are very functional. You're actually having the patient move. You can have them do some at home. There's a lot of at-home things. There's not as like set procedures though, so it's kind of, you have to be sure that you know when the athlete is ready and how many they have done. And there's been effects to show up for 48 hours, up to 48 hours with both of these. So if you do one session on Monday, then they should still be having effects from that session Wednesday. So there's no need to do them day after day. I think the main thing that is similar with both of these, the goals of the treatments, most mobilizations, like I mentioned earlier, are to reduce pain and increase range of motion. There's also very set contraindications and indications for mobilizations. Some of those contraindications include hypermobility, infectious arthritis, metabolic bone disease. There's a list, and so I think the main thing with mobilizations is, yes, if you see them done in the clinic and you're like, oh yeah, that's cool, you're just, pulling a little bit on the ankle joint. But no, there's a lot of anatomy that goes into these, and that's what you need to know. And there's definitely, they have shown a lot of positive results, but before you start implementing them into your practice, you really need to learn the procedures and the goals and all the information that goes along with them. So I wanted to look at what compares the Mulligan's versus Maitland's in the treatment of shoulder impingement. It was a very small literature review, just 3 articles I looked at, and like I mentioned, just comparing the different effects of the mobilizations. As a new clinician, I have seen Maitland's, or I was taught Maitland's in undergrad, and then I have definitely seen a lot of clinicians using mulligans. I have never been taught that yet, so I wanted to see, how do they compare when treating the same thing. So the first article I found, this was they had 4 different interventions for the treatment of shoulder impingement. There's only 33 subjects, and they're split into 4 groups, so the groups were small for each treatment. The interventions were exercise only. Then there was an exercise with glenohumeral mobilizations, so that would be Maitland's. So they did grade 1 or grade 2, so that was just for decreased pain, anterior, posterior, inferior glides, whichever one the subject needed most. So it wasn't just a set procedure for all subjects in that group. They looked at what their limitations were, what each subject needed themselves. And then they did 3 sets of 30-second mobilizations. Then the next group was exercise with mobilizations with movement, which is mulligans. They did 3 sets of 10 reps, and they did the same direction. It was, I want to say shoulder flexion, but I think they also they individualized it too, because mulligans is usually all, you can change the different degrees. And then there was a control group. So what was found was there was no really statistically significant results found between groups. All groups showed improvement, which is a great thing, but there was no group really stood out significantly. The mobilizations with movement group, though, they did show a little bit higher percent of change, but nothing to be statistically shown. For the limitations, like I said, there was a small sample size. The inclusion criteria was pretty broad. There was an imbalance in groups. Also, a lot of these joint mobilizations, it's not just you're doing it in one session and that's it. They are usually done over time, and also having range of motion exercises afterwards, and strengthening and stretching exercises. And none of these all implemented them, but it wasn't done regularly. So then the second article I found, it compared the immediate effects of mobilization with movement. And then that was the only thing done. And then there's a sham technique also. So there's 42 patients, and they were divided into 2 groups. The ones that received the mobilization with movement did shoulder flexion. They did 3 sets of 10 repetitions, and then a 30-second break in between sets. Subjects then received 4 treatments over 2 weeks. What I want to address here is that it showed pretty set that they did 3 sets of 10 repetitions. But with mulligans, like I mentioned earlier, sometimes if the athlete can only do 6 sets in the first rep, 6 repetitions in the first set, and then they start to receive pain, then it's okay to stop. It's still a successful treatment. You just didn't get up to all the way to 10, and so I took a second look, and I just wanted to they did all do 3 sets of 10 reps. So I don't know if all of them just didn't have pain, which would be good, but just wanted to a little insight on that. And then the sham group was just active shoulder flexion with no pressure in the actual right spots. So the patients who received 4 sessions of mobilization with movement, they exhibited a significantly better outcomes for pain during shoulder flexion, pain-free range of motion, and maximal shoulder flexion and external rotation. So this group definitely showed positive influences with mobilization with movement. This was done with no exercises. Like I mentioned earlier, mobilizations need to be done with therapeutic exercises for the best results. And so that was a limitation of this, is that they just did the mobilization. And then the pain-free shoulder flexion and the maximal shoulder flexion exceeded the MCID. And so it actually, like, those were not statistically significant. The next article was to determine the effects of scapular mobilization, so that would be Maitland's, on function, pain, range of motion, and satisfaction in patients with impingement syndrome. So there were 66 participants, which was quite a bit. They were randomized into 3 groups. All 3 groups received at-home exercises to do, and then all subjects received 9 treatments in 3 weeks. So this was a pretty long, ongoing research. So scap mobilization was the first group. They did superior and inferior glides, rotations, and distractions. They applied that 3 sets of 10 with a 30-second interval between sets. So they did the same repetitions as the first article did with Maitland's too, but different directions. Sham mobilization, they placed hands randomly on the scap, so they just kind of pretended. And then there was just a random group who just only did exercise. They did a lot of stretching and strengthening. So for the results of this study, there was no significant difference between groups. All groups did show increases in shoulder motion function and then decrease in pain. And so no group just stood out. So the group that just did the exercise, they improved, and the group that just did scap mobilization, they improved. So there's actually like no absolute control group, like no group that did nothing, and then no group like that did a really good combination of mobilization exercises. Yes, the subjects received at-home exercises, but you can't prove if they did those or not. So what did I get out of this little lit review, and what do I want you guys to get out of it? I think that with my personal opinion and what I have heard from colleagues and professionals, and also what I've read in articles, I would choose Mulligan's mobilization with movement technique along with therapeutic exercises, and I think that would result in an increase in range of motion and a decrease in pain in patients with shoulder impingement. Now that is a very opinionated statement, but with my research and clinical expertise, that is what I would go along with. These are the references I used, and I hope that you learned a little bit about the comparison and differences of Maitland's mobilizations versus Mulligan's mobilizations. Thank you.